My name is Keshet Ronan. I'm the Associate Director of the MPH program in the Department of Global Health. We are excited to have you all here. Of course, our students, but also the supporters and supervisors and mentors and friends and family, if there are any in the audience, who really kind of facilitated our students' work. This is an exciting moment in our students' academic career since the presentations that they'll be sharing today are kind of a culmination of work that they've been doing over the last 1 to 2 years. So we are proud and excited to hear about your work. I want to start by thanking Salami Detta and Lida Ebadani for organizing and helping to moderate today's session. So just a quick overview of the structure for today. So each student will have 10 minutes to present and 5 minutes for questions. As you can all see, this session is recorded. While you're presenting, please keep an ear and eye out for Lida, who'll call out, he'll give you a 5-minute warning, a 2-minute warning, and tell you when your 10 minutes are up. If you notice that you're running out of time, please adjust accordingly, start kind of skipping over slides so that you can stay within the 10-minute timeline. We have 3 presenters, so we do want to stay on time so that everyone has time to speak. There will also be a timer in your Zoom window, so that can also help you keep track of time. Audience, we welcome audience questions. We encourage you to participate. If you have a question that you'd like the student to address, please either put it in the chat or raise your Zoom hand in the Q&A part of the student's time. And students, if we run out of time, please answer questions publicly in the chat box so that everyone can read the responses. Housekeeping, please keep yourself muted unless you're presenting. We love seeing people's faces if you have the bandwidth to turn your video on, but if you don't, no problem. And I think that's all the housekeeping. So with that, just pull up the program. Our first presenter is James Lee, whose thesis is entitled Caregiver Skills Training Program for Families of Young Autistic Children Globally, a Systematic Review. Go ahead, James.
All right. Thank you, everyone, very much for this opportunity. So I'm going to go ahead and share my screen. Okay, I think you're seeing the right screen now.
Yep, that's great.
Okay, so let me just move you so I can see you. Okay, so thank you again for coming to my presentation, which is entitled Caregiver Skills Training Program for Families of Young Autistic Children Globally, a Systematic Review. My name is James Lee, and my committee chair is Dr. DM Nguyen in Global Health, and my committee member is Dr. Jill Locke in Psychiatry. So I want to start by giving some brief information about autism. Autism is a neurodevelopmental condition that affects how individuals interact with the world around them, including challenges in social communication and behaviors. In the US, autism is primarily diagnosed using the DSM-5 criteria, which is a standardized manual for mental health conditions. While traditional diagnosis can occur as early as 14 to 16 months, new advancements in technology, such as eye tracking, are helping researchers identify signs even earlier, allowing for a quicker intervention and support. In terms of prevalence of autism, autism affects approximately 1 in 36 children in the US as of 2024. But globally, there are about 1 in 100 children being diagnosed with autism in a systematic review reported in 2023. So there are evidence-based practices in autism that can improve the quality of life for many autistic children and their families. And these are primarily behavioral or psychosocial interventions to improve outcomes across child and family levels. But in terms of the accessibility of these EBPs and services, they are not very equitable. In fact, there are lots of access issues that are highlighted among a lot of the low to middle income countries. In a previous literature review, we found that many low to middle income countries, or LMICs, also fall under the category of low resource settings. In these regions, there is often limited access to critical services such as diagnosis of autism, treatment and education, rehabilitation, or medical care for individuals with autism and their families across their lifespan. So one way to address these barriers is through capacity building strategies. So for example, parent-mediated intervention in autism can empower families to implement these evidence-based practices in their own homes, helping to bridge the gap in professional support and improving outcomes for many children with autism and other neurodevelopmental disabilities in these low-resource settings. Around the world, many children with autism and their families lack access to these quality care and interventions. So in response to these difficulties, the World Health Organization, the WHO, developed the Caregiver Skills Training Program in collaboration with the Autism Speaks. The CST, the Caregiver Skills Training Program, is an evidence-informed caregiver-mediated intervention developed to meet the needs of caregivers raising children with developmental challenges, such as autism. CST was designed to bridge the significant service gap in low-resource settings, in which caregivers often experience limited access to autism care. So having an autism diagnosis is not necessarily a requirement for participating in the CST program, given the potential challenges of obtaining a diagnosis in these low-resource settings. So for my thesis, I conducted a systematic literature review to explore how CST is being used in these low-resource settings with these two research questions. One, how is the WHO CST program adapted to different cultural and contextual needs in many low-resource settings? Two, what are the primary focus and outcomes of implementing CST? So in this systematic review, I used a systematic search process in which I used 4 databases and specific keywords to identify potential articles. Using a set of inclusion criteria, I screened over 4,500 articles using their titles and abstracts. I identified 19 studies that were full text reviewed with another person for reliability, meaning we went in to each of the 19 articles, and then we read the whole article to see if an article would fit the inclusion criteria. And then we had a total of 13 articles to be included in this review.
James, you have 5 minutes.
Thank you. So when coding the articles, I created a Google Forms to extract the data from each article. It included items related to study information, such as the number of participants and participants' demographic information, and information related to the CST, so adaptation of CST and reported use of cascading model structure and reported outcomes. So there were a total of 433 caregivers and 186 children represented across these 13 studies, and 93% of the caregivers reported as being mothers of children with autism and other developmental disabilities. And there were 8 countries represented, including Ethiopia, Hong Kong, India, Italy, Serbia, South Africa, Taiwan, and the US. So as you can see here, not all of the countries would be identified as low to middle income countries. In fact, there are some high income countries that have participants who reported themselves being in low resource settings. So those are 2 different concepts. So most had autism diagnosis, and there were some comorbid conditions with such as intellectual disability, communication disorders, ADHD, and so forth. So CST was intentionally developed with adaptations in mind. So studies on CST adaptations primarily involved linguistic and cultural adjustments and adaptations, and content and focus modifications and delivery adaptations. So linguistic and cultural adaptations included things like translating materials, altering examples to reflect the local context, and engaging cultural advisory groups, and simplified materials for low literacy population. And content adaptation focused on adding relevant topics and examples, and modifying age ranges and removing some irrelevant content for their context. And delivery adaptations emphasize some of the modifications that were used for online delivery they changed the delivery format to group delivery, or they added the components such as group exercises or daily reflections, some more extra support for caregivers. This is a table for all outcomes across child and caregiver and programs, and I know it's difficult to read. So to synthesize, studies on CST reported generally positive caregiver feedback on program feasibility, acceptability, and session relevance, although some caregivers suggested improvements such as extended discussion time and more tailored content for their specific context. While caregivers appreciated the increased knowledge and confidence in online accessibility, challenges also included logistical issues, cultural mismatches, and mixed views on telehealth versus in-person sessions, with some caregivers noting difficulties with specific content and facilitator preparedness.
James, you have
So,
2 minutes.
Okay, this is my last slide. So to sum up, cultural adaptation is essential for effective intervention, intervention implementation in these diverse settings, extending beyond language to include factors like context and methods and goals and so forth. So we can think about some of the tools that exist in implementation science, such as cultural adaptation checklist or the frame, which can guide this systematic cultural adaptation process. So we can get some help differentiate the pre-implementation activities and implementation activities, and maybe even the post-implementation activities in regards to CST. So future research should prioritize structured cultural adaptations, again, to ensure these EBPs, not only the CST, but other EBPs are also accessible, effective, and sustainable for marginalized populations globally, particularly in low to middle income countries. That's everything that I had. Thank you for your time.
Thank you, James. Great presentation and really nice project. We'll open up for questions. Any questions from the audience? While we wait for audience questions, could you share some examples of some of the cultural adaptations that you saw? And then related to that, did you see evidence in the literature that the interventions that had more significant cultural adaptation were more effective, or were you not kind of able to see that from the literature?
Yeah, so I think there's a long-standing debate, the notion of we want both fidelity and flexibility in intervention adaptations, right? So when we think about cultural adaptation, it really is related to these modifications that we make to an intervention, so we can make it more culturally or contextually relevant, and that can be for cultural reasons or linguistic reasons or other reasons. For example, during COVID, a lot of our psychosocial interventions across all fields really had to transition to online, and I think that's one type of adaptation that we can make. But there's also this notion that we want to preserve these core components of an intervention. So these are some of the intervention components that we're not supposed to really touch on in terms of modification, because if we modify these components, then it's not the same intervention anymore. It almost becomes a new intervention. So when the WHO was developing the CST with the Autism Speaks, I think they were aware of these issues where they try to intentionally make the intervention very broad, and there were certain sessions, and they have actually developed a adaptation guide that's also on the WHO website, that the researchers who do CST are supposed to follow. So this includes things like, if home visit is a essential component in CST, so the researchers and the master trainers would do home visits, but obviously for cultural or other reasons, home visits are not appropriate in a lot of these settings. So then we would allow for these home visits to be online, or to be like over a telephone or something like that, so that we can still try to preserve some of those intervention components while trying to accommodate for the local context, if that makes sense.
Yeah, thank you. Yanfang, go ahead.
James, thank you for your wonderful presentation. In my observation in China over summertime, I found that actually in many families with autism kids, the parents divorced and then mom became the major caregiver. And in other cases, even mom need to be the bread maker and earn the income for the family. So the grandparents became the caregiver. In your systematic review, have you found any of the study regarding like the social structure as well as the grandparents serve as the caregiver?
Yeah, that's a great question. So in the reported studies, in the 13 studies that were included here, we primarily saw mothers being the primary caregivers. I think it was something like 93% of all of the caregiver participants reporting it being mothers. In other autism literature and other sort of autism intervention literature, we do see the increase of extended family members being the primary change agent in these interventions, because to reflect, like you said, the kind of the different sort of a family structure and who the main caregivers are, because a lot of the autism interventions, especially in the early childhood age, we want to focus on increasing the capacity of main caregivers, whoever they might be. It could be the moms or the dads, or it could also be extended family members or nannies, or the teachers, whoever is mostly with the child. So I think that's also a implication for future research, to think about how we can better utilize other extended family members to really, if the whole purpose is to deliver these EBPs through non-specialist, then I think those non-parent caregivers should also definitely be in consideration for these interventions.
Thank you so much, James. Your timing is perfect. We have 5 seconds left on the clock. So if anyone has other questions, please feel free to put them in the chat.
Thank you very much.
But we will move on to our next presenter, who is Vicky Lee, whose thesis is entitled Identifying Risk Factors for HIV and Syphilis Co-Infections in KwaZulu-Natal, South Africa. Go ahead, Vicky.
Great, thank you so much. Thank you for everyone for being here as well. Good morning. My name is Vicky. I am here presenting my thesis on identifying risk factors on HIV and syphilis co-infections in KwaZulu-Natal, South Africa. Here is my brief agenda for today. I want to start off with some background and address my positionality as a researcher from a high-income country working in global health. I want to acknowledge power dynamics that are inherent to cross-cultural research and my own position of privilege. I did not collect this data myself. This project is a secondary analysis from a primary study where local collaborators and investigators from the community were instrumental in the data collection, and I hope that this work is beneficial to the community involved. Important information to know as background for this project is that having HIV and syphilis infections simultaneously can present significant health challenges, as co-infections could lead to increased transmission of both diseases and worsening health outcomes for the individuals. From extensive literature and what we know in public health is that social factors can influence these co-infections dynamics and contribute to healthcare disparities. In terms of comparing guidelines, the CDC recommends regular syphilis and STI screening for people living with HIV, which means that regardless of any symptom presentation. In comparison, South Africa's guidelines focus on prioritizing symptomatic individuals and screening that can occur during pregnancy as a public health intervention to prevent congenital syphilis, which means that people living with HIV who are not symptomatic and are not pregnant can be missed. The South African HIV Clinician Society, they advocate for making STI, notably syphilis screening, more accessible for key populations in order to better address risk factors. And this could have a lead to more targeted screening that could be necessary. These factors underscore the need for the study, which has two main aims. First, to determine the prevalence of syphilis among individuals diagnosed with HIV in KwaZulu-Natal, South Africa. And second, to investigate demographic correlations with syphilis co-infection. And this study, I would hope, could better contribute to the understanding of syphilis co-infections among people living with HIV and identify possible disparities that could highlight the need for early detection, early screening, and tailored interventions. Okay, so looking closer at the methods used in this study, the study design is a secondary analysis of a data set that had involved a cohort data that were collected from a holistic HIV clinic in the Umlazi township. So my analysis is a cross-sectional analysis that focused on the 2,580 people living with HIV who all sought care and HIV testing at this clinic. We included individuals who, of course, had a positive HIV diagnosis, who had syphilis screening, and excluded pregnant individuals and those who had recently received antifungal treatment. The data collection had involved gathering socio-demographic medical information at enrollment, as well as receiving standard of care testing and treatment per the local guidelines. Next, let's review the data analysis. We used Poisson regression models to derive some prevalence ratios of variables in order to assess any correlations, and also multi-variable models in order to adjust for possible confounders. The primary outcome of this study was having a positive screening on the syphilis screen, and that was determined by an RPR screening, a rapid plasma reagent screening. The exposures we examined included partners' HIV status, alcohol, tobacco use, circumcision, employment. The list goes on.
Vicky,
Now let's look at the result from the analysis. So in terms of prevalence, out of the 2,580 adults diagnosed with HIV, 123 or 4.7% screened positive for syphilis. This 4.7% prevalence of syphilis among those living with HIV is very consistent with estimates across other studies in the KwaZulu-Natal, South Africa region. This rate is notably higher than the national average for the prevalence of syphilis, which is estimated to be in only 0.5% for the general population. And the higher prevalence of syphilis among people living with HIV can be explained by immunological reactions, kind of the acquisition transmission that I had talked about previously. And another reason why could also be that it's important to note that HIV disproportionately can affect areas like KwaZulu-Natal, where there's higher levels of segregation and lower SES. Now let's look at some demographic characteristics of the cohort, as well as some of these graphics, where in terms of age distribution, 42% of participants were between 18 and 29. Females made a slightly larger majority of the cohort, making 58.2%. Roughly 1/3 of the cohort had a CD4 count of 200 or lower. Looking at some additional demographic information regarding marital status, you can see that most participants were never married, representing 93% of the cohort. In terms of education, 50% had secondary education or higher. So those are the characteristics, and now moving on to some of the association that we're seeing in this data, where, as you can see in the first row, for every 10-year increase in age, the prevalence of a syphilis co-infection decreased by 24%, suggesting that younger individuals may be at higher risk. Male circumcision was associated with a lower prevalence of syphilis, while having a partner of known HIV positivity and cigarette use were both associated with a higher prevalence of a syphilis co-infection. This table is now kind of adjusting at a multivariable level, where some of the variables I had mentioned previously, like younger age, circumcision, tobacco use, and having a partner with HIV are associated with syphilis infection when adjusted for age and sex. In the combined model, which adjusts for all of these variables at once, the only variable that remains statistically significant is having an HIV positive partner. This could indicate that among some of these variables, that there is some collinearity, given that they were no longer significant when adjusted for each other. So in conclusion, having a partner with HIV, younger age, and tobacco use were significant risk factors in this study for a syphilis co-infection among those with HIV. I want to point out that all of those who did screen positive for syphilis in this study, they were all asymptomatic, as in there were no signs of any genital lesions or secondary symptoms of syphilis. And so this finding, and all of these findings, could suggest that a need for public health interventions to both address asymptomatic spread and also target risk factors, potentially including partner testing, tobacco cessation programs. These findings underscore the importance of improving and expanding syphilis screening practices among those living with HIV, particularly in areas that deserve more equitable healthcare access. And thank you so much for listening to my presentation. Happy to take any questions.
Thank you, Vicky. Great work. Really nice presentation. We now move into questions. Does anyone in the audience have questions? I'll kick us off again. I had two questions. One is just, I wanted to hear a little bit more about your reasoning for excluding pregnant people. Since I know that, syphilis screening in pregnant people is like a very high priority because of the risks to the infant. And then my second question was about why you think tobacco use is associated with a higher prevalence.
Great, yes, thank you for those questions. To your first point about pregnant individuals, this was a secondary analysis of a primary project that had originally already excluded pregnant people. And that is, I'm not trying to say that is a cop-out necessarily, but I think that in some of these research questions, the immunology interactions that could occur during pregnancy might affect kind of the infection transmission and susceptibility. And so the original study was also about HIV and particularly Cryptococcus, which is known to be increasingly susceptible in cases of extreme immunosuppression. And we know that pregnancy is immunosuppressive. So kind of like that was definitely helpful for my study as well, but that was definitely a part of the original primary study. And I definitely agree that pregnancy and kind of HIV plus syphilis is important given the fact that congenital syphilis is quite can be quite severe and extreme. And to your second point about tobacco use, I think that I was surprised and not surprised at the same time that this was a possible association with increased syphilis co-infections. I think that in my research, people talk about both alcohol and tobacco use as kind of behaviors that that could be a part of social networks where there are more higher prevalence of syphilis and HIV, for example. I think that it's important to know that also culturally speaking, alcohol and tobacco, that means different things in different cultures, and that in general, it's good to stop smoking tobacco, but how much of that is 100% related to syphilis co-infections in my cross-sectional analysis without like a controlled setting, I'm not sure, but thank you for asking that.
Thank you. Thanks, Vicky. Looks like we have 2 more questions. Yanfang?
Thank you, Vicky, for your wonderful presentation. I want to know a little bit more about the context for your study for HIV services, whether that was incorporated into the PHC primary care setting or not. And another thing I was wondering was regarding the policy implementation. So for South Africa last year, they just passed the legislation for the national health insurance. So I'm wondering, like for the project ongoing, whether that would influence the STI screening. Thank you.
Yes. Your first question about the care that the participants received with regard to their HIV. This study was based in a clinic where these individuals were where the primary goal of the clinic itself is for clinical care and quite holistic care as well. So this research was just kind of like, in addition to the primary goal of the clinic, is like, what can we understand about this population? So I want to say that the clinic, I believe, is like not up and functioning anymore, but when the study was done and when it was when the population was followed for a few years, like they received holistic care the whole time. Yeah, thank you. And then to your second point about like the policy changes that are happening in South Africa, I can't answer that necessarily, but I think that makes me really hopeful about like if insurance is expanding in South Africa, that preventative care, I think we know that it becomes more of a priority in those healthcare systems. But I can't speak more to that. Thank you.
Thanks, Vicky. Perfect timing again. Amaya, I saw you had a question. Could you put it in the chat, please? And then Vicky can address it. Thank you. All right. Thank you. And with that, we'll move on to our third and last presenter, Ayan Ali, whose capstone is entitled Policy Analysis of the Washington Department of Health's Breast, Cervical, and Colon Cancer Health Program. Go ahead, Ayan.
Hello, everyone. My name is Ayan Ali. I'm a second-year graduate student completing my master's in public health in the Global Health Department. I'm also working on completing a graduate certificate in international humanitarian response. This is my oral visual presentation for my MPH Capstone, a project that I worked in partnership with Public Health Seattle King County's Breast, Cervical, and Colon Health Program, and also with their assessment, policy development, and evaluations team. My committee members are Dr. Chris Johnson from the APD team in Public Health Seattle King County and Dr. Yanfang Su from the Global Health Department. Before I get started with my presentation, I wanted to touch a little bit on my positionality statement. I am a Black Muslim Somali woman. I'm the eldest child of 10 to 2 hardworking, dedicated, and loving people, my parents. I also am the first person in my family to graduate high school, college, and now hopefully pursue an MPH degree. My lived experience have always been at the core of everything that I have done until this point in my life, which is why I've always been very intentional about the type of work that I wanted to do, whether it's research or even the type of courses that I took both in undergrad and now in graduate school. I am able-bodied and my research interests focus on maternal and child health, and I've done projects on vaccine access, and now my capstone is on gynecological cancers. I've had access to both private and public education throughout my life, thanks to my parents. I'm also multilingual and speak Somali, English, Arabic, and Swahili. So a little bit on my project background. As I alluded to earlier, I was very intentional about the type of work that I wanted to do. And when it came to choosing an ILE, I wanted to do a capstone project because I wanted to ensure that whatever deliverable I come up with would be useful to my community. So in May of my first year of my MPH, I started an internship with the King County's executive office, whereby my mentor, Abby Rodriguez, connected me to Public Health Seattle, King County's Assessment Policy and Development Evaluation Team, and the BCCHP leadership. After that connection, I discussed with them my interest in maternal and child health and learned about the BCCHP program and its objectives in addressing and promoting health equity by addressing cancer screening disparities locally. And I have throughout this project worked with Colleen Pachenko, who's also an alumni of this program, and Dr. Chris Johnson. And shortly afterwards, I started working on putting together my project proposal and started working on the project. So despite both breast and cervical cancers being preventable through regular screenings, early diagnosis, and even immunization for HPV for cervical cancer, they still both pose a significant health burden and mortality globally, with said burden projected to keep increasing by the year 2050, according to a 2022 cross-sectional study of over 36 types of cancers from 185 countries. And there's even additional disparity with regards to the geographic location of the person affected by these cancers. There's disparity across age, sex, and Human Development Index, with said disparities projected to widen even further by 2050. Cancer cases and deaths are expected to rise by 77% and 90% respectively in 2050, with a threefold increase in low human index countries, so lower income countries, whereby their cases will increase to about 142% versus the current 42%, and the deaths will increase to about 146% versus 57% if there aren't interventions. With that background in mind, I want to also give a little bit about what the BCCHP program entails. This program is part of a nationally funded CDC program, whereby states receive funding from the CDC to support with their local communities cancer diagnosis, screening, and treatment for some. The Breast, Cervical, and Colon Health Program, or the BCCHP program for short, is one of 5 statewide prime contractors, and the BCCHP service region includes Clallam, Jefferson, King, and Kitsap counties.
Ayan, you have 5 minutes.
Okay, so for the breast and cervical cancer program in particular, they pay for both screening and diagnosis for anyone living within the King County service region. And this includes people with no health insurance or people with insurances that have high deductibles and are living in households with the annual income below the federal poverty level. And BCCHP sets that to about 250, I'm sorry, that's a typo, 250 to 300% below the federal poverty level. Also, as you can see on the right here, this gives more detail on exactly what it is the BCCHP covers. And also just to further emphasize, within the service region, we see disparity by racial ethnic background. This is for breast cancer. We also see by location, where you see the percentage of King County women aged 21 to 64 who did not receive breast cancer screening within the recommended timeline. And this is similar for cervical cancer screening. And this is another visual of the geographic location. So for my role in this project, it was basically to conduct a detailed analysis of what the program seeks to understand, so what the program does and how it's addressing community health needs. And I did that. I started off by completing a literature review and analyzing both CDC and King County data to assess the program reach, structure, and demographics. I also conducted key informant interviews with both state and local program implementers to learn more about what the specific needs of the program are, how it's changed over the years, and so forth. And then after doing that, I completed a qualitative data analysis of those interviews and developed a code book and analyzed using the Deduce software. And then the themes that emerge from my analysis are what's gonna inform my key recommendations in my report. So for my findings for my findings, the first one was funding inconsistencies and how those hinder successful implementation of the program. So a lot of what my key informants informed me through the interviews was that the program initially had a lot of funding, but throughout the years, there's been funding cuts. And also during COVID, as a result of the pandemic, there also have been funding cuts. And then another key finding was the need for authentic awareness and understanding of the program. And this is in part of the program beneficiaries not really understanding that there's this program available to you if you fit the criteria and the eligibility requirements. Another key finding was the continuous impacts of the COVID-19 pandemic and its impact on the health system disruptions. As we know, to focus more on the pandemic, a lot of preventative measures had to take a backseat, and this is the case for cancer screening within the program. And then lastly, I found that program policy discrepancies between the state and federal level and their impact on both the beneficiaries and program implementers.
Ayan, you have under 2 minutes.
Okay, moving forward, I'm hoping to finalize and submit my policy analysis report to Public Health Seattle King County's APD and BCCHP teams. I also am hoping to develop a policy brief based on my analysis findings, and both of these are my key deliverables for the project. And lastly, for my own personal learning, I hope to apply the lessons learned from this project in my future work as a public health researcher. I plan on pursuing a PhD, MD degree in the next few years with a focus on medical anthropology and gynecological cancers. So this will also be a key part of that. And lastly, I would like to provide some key acknowledgements. Thank you to my parents for all their hard work in getting me to where I am today. Thank you to my extended family, uncles, aunts, cousins, and some of them are in attendance today, and for always being in my corner and always listening to me rant about my never-ending complaints about being a Black woman in academia. Thank you to my grandmother for always checking on me and staying up late with me during study sessions and always praying for me and bringing me snacks. Thank you to my committee members, Dr. Chris Johnson and Dr. Yan Feng Su, for their guidance and support throughout the past year. And lastly, thank you to my advising and GH faculty team, Julie, Salam, Will, Lida, Professor Robbie, Steve, Awa, Kashet, and Deepa for all their support throughout my time in the program. And thank you to my friends and UW and Global Health alumni, Sumaya, Sandra, Deqa, Nishma, Smira, and my mentor and my very close friend who played a key role in me getting into this program, Nafiso Aiga. Thank you, everyone. And I'll take questions now. Go ahead, Awa.
Yes, congratulations. Very, very nice job. I do not have a question. Mine is more of a comment. I just wanted to say that I have really, really admired all that you've done at SPH, at DGH, and you really are always intentional, like you say, about what you do, what you get involved in. And I truly admire you for that. And you are a model for someone who really walked their talk. So thank you for touching so many of us. And I look forward to seeing what you do in the community. Congratulations.
Thank you, Awa.
Thank you, Ayan. My internet is flaky, so I have my video off, but thank you so much. And thanks, Awa, for saying that. I totally agree. Any questions from anyone in the audience? I'll kick us off again. I wonder if you could expand a little bit more on the theme around inconsistencies between federal and state guidance or regulations. I can't remember what the wording was.
Yeah, so so in for the eligibility requirement, so everyone has access to screening, free screening through this program, but to receive, after you receive your screening and you get a diagnosis, to receive a treatment, you have to be documented basically. But within Washington State, as part of our legislature, we're not supposed to ask about people's documentation status. So something really good that the program does is they support people in applying for Apple Health or state insurance so that they can continue receiving treatment through that. But something that from my key informant interviews was that sometimes there might be family members of residents that live in this state that are visiting them. There was a case about a woman who visited her son from a different state where there wasn't such a program. And she received treatment here and was able to support her child who was also sick while she was also receiving treatment. But there is that inconsistency whereby if she was in a different state where, you know, the rules are different, she might not have had access to that. Also, this is a federally funded program. A lot of the rules sometimes are set at the federal level, even though we might have state policies that can curb these set policies. That inconsistency might be confusing, especially when it comes to raising awareness about what the program entails and how people can utilize it.
Thank you. Thanks, Ayan. Especially relevant as we enter a new administration. Go ahead, Yanfang. Oh, Chris, did you want to add something before I move to the next question?
Yeah, if you don't mind, I apologize. I don't know. I just can't find the hand raiser today. Maybe it was the
No
cyclone.
worries.
Thank you. I wanted to ask, Ayan, initially you had wanted to look at, we were talking about program reach, and both of us were interested in learning how many undocumented people were served by the program. And what we found is that the program does not record citizenship or residency status anywhere. And I think given the last question and your result, people would be interested to, if you shared why. Do you remember if you can remind people about why we were unable to look at citizenship status of people served by the program?
Yeah, because it's as part of Washington state legislature, we're not supposed to ask people about their citizenship or documentation status, and this is protection for the individuals. I mean, like you mentioned, Keshet, we have a new, I'll say, violent administration coming in, and they've made it very clear about how they're going to treat immigrant and refugee populations once they're in power. So we always want to make sure we're doing our part in ensuring that people that come to us seeking healthcare don't leave hurt. So we don't ask about citizenship status. We make sure that if people are not eligible through documentation, there are other avenues that they can still continue to find support, because it doesn't really make sense to tell someone, oh, you have cervical cancer, you have breast cancer, now just go off because you're not eligible. So we support them by applying for Apple Healthcare and then making sure we're in connection with them throughout that process, because applying for Apple Health takes time. And that's also one of the things we hope through my report and the policy brief, we can encourage that we make that time slot shorter, because a cancer diagnosis is not an easy thing to deal with and having to jump through all these other loopholes. We want to minimize as much as we can.
Thank you, Ayan. I saw there were a couple more questions, but we are out of time. And so maybe those people could follow up with you by email if you want to put your email in the chat. So I will close our session by congratulating all of our students. Thank you all so much for your work. We're really proud of you and wish you all the best in your next steps. Thank you everyone for joining.